Hi everyone, welcome back to 𝗕𝗂𝘂𝘶𝗵, broadcast from SobolevSpaces. In this video, I talk about counterfactual questions, data-driven evidence, what-if questions and their connection to policy making are the main topics of today's lesson. Now, be sure to watch until the end and compare the takeaways with your notes. I prepared extra material for this video, so click the link in the description and it will be sent to your inbox. In 1999, the Journal of American Medical Association published an article. It outlined principles of informing public health policy and clinical practice. It argued that the basis for medical decisions should be data, not expert opinions. Then the revolution starts. Data are at the core of evidence-based medicine now. The basic method of health research is to quantify difference between treatment groups. We compare health status with and without treatment. When the status differs, we say that the treatment worked. The difference in outcomes tells us whether the treatment is working. Comparing treatment outcomes is not a new concept. It's even becoming part of the legislation. Take the Affordable Care Act, commonly known as Obamacare. It links changes in practice and policy to comparing treatments. Treatments with better results should be adopted by hospitals and health authorities. Simple, right? For example, drug-eluting stents for the treatment of heart disease. Before their widespread use, stents were bare metal. What is stent anyway? It's a small mesh metal tube. Doctors insert them into a blood vessel to keep it open. Stenting began in the mid-1980s. Since then, we see major improvements in their design, all thanks to data from dozens of trials and observational studies. You see, stents act as a scaffolding after angioplasty widens the artery. The tissue grows around the stent, holding it in place. But sometimes this growth blocks the artery again, and this is called restenosis. Enter drug-eluting stents. They reduce the chance of restenosis. How they do that? They are coated with a medication. It's slowly released when the stent is in the artery, helping it to stay open. Simply put, bare metal stents work well, but observations show they have a higher restenosis rate than drug-eluting stents. And now we use them instead. Data bring a change in the practice of stenting. In causal analysis, we compare two counterfactual situations. One in which the entire study population receives the same treatment, and the other in which the same population receives a different treatment. Why do I call them counterfactual? Well, in reality, the study population is made up of treatment groups. Some patients get one treatment and some other get a different one. Still with me? Okay, here's an example. In his 2012 paper, 𝗖𝘂𝘂𝘶𝗵 compares angioplasty and bypass surgery. Both restore blood flow to the heart muscle, but in different manner. Angioplasty widens the narrowing of the artery and a stent is then inserted. Surgery connects the arteries to the aorta to bypass the narrowing. This graph from the 𝗖𝘂𝘂𝘶𝗵 study shows almost 200,000 treatments of stable heart disease. Angioplasty is in green and bypass surgery is orange. The bars show the number of treatments across propensity scores. Each score describes the expected frequency of surgical treatment. It's determined by a combination of clinical and hospital factors. As you would expect, the orange bars are higher on the right. Those with a higher score are more likely to get surgery, right? On the other hand, patients with a lower score are more likely to undergo angioplasty. And the green bars are higher on the left. Everything as expected. Unexpected are green bars on the right. Some patients with a higher score end up having angioplasty. Here's how I summarize this graph. Patients with a higher propensity for surgery mostly get surgical treatment. Yet a significant number of them have angioplasty. Patients with a lower propensity for surgery mostly undergo angioplasty, although some have surgery instead. Surgery and angioplasty with stenting are two different strategies for restoring blood flow. Bypass surgery is a major intervention. It requires a heart-lung machine and postoperative care. Angioplasty, on the other hand, quickly restores blood flow under local anesthesia, and the recovery period is short. Yet surgery and angioplasty are not simply different treatments. Their long-term outcomes are different too. For example, surgery is known to increase the risk of a stroke, but after angioplasty, patients may need to repeat their treatment. So, some patients are selected for angioplasty, even though most patients with similar profiles undergo surgery. Bypass surgery rarely needs to be repeated. What if they had surgery instead of angioplasty? How many repeat treatments could be avoided then? Some patients have bypass surgery even though most patients with the same clinical profiles undergo angioplasty. Angioplasty usually results in fewer subsequent strokes. What if these patients had angioplasty instead? What percentage of strokes would have been avoided? This shows how observations can lead to counterfactual questions. I see repeat angioplasty and I wonder if patients would need it if they had bypass surgery instead. I see strokes several years after surgery and I wonder if this could have been avoided had angioplasty been done. What if questions are common in counterfactual thinking. We explore possible alternatives to events that already occurred. We imagine how the outcome might have been changed if the preceding events had been different. I take an aspirin and the headache goes away. I wonder, would it have gone if I hadn't taken the aspirin? But these questions cannot be answered with data alone. We observe events and we can recognize an association. Yet statement of causation involves reasoning. By considering confounding, we may rule out their effect on treatment and outcomes, and then we can use adjustment formulas to estimate the treatment effect. But what if questions involve counterfactual reasoning? We speculate whether the outcome would have been different had the treatment been different. Here's the most common type of what-if reasoning in public health. The risk reduction that could have been achieved if exposure had been reduced. Back to our example. What would be the impact on the health system if all patients suitable for bypass surgery had it instead of angioplasty? What proportion of repeat treatments would have been avoided? Another question, what would be the impact on the patient population if all eligible for angioplasty had it, rather than surgery? What proportion of strokes could have been avoided? These questions follow causal reasoning. If patients receive an appropriate treatment, one would expect the number of adverse outcomes to decrease when that treatment is replaced. Then we ask, what could have been achieved if the inappropriate treatment had been removed? Again, these questions cannot be answered by data alone. To establish the causal effect, the observed and potential outcomes must be compared. We are comparing observed and counterfactual risks. I took an aspirin and the headache went away. Can I say that the aspirin made it happen? If I had not taken the aspirin, would the headache gone away? I cannot say, because not taking aspirin is counterfactual to my treatment history. To complicate matters, we must assume that the treatment may or may not lead to the desired result. In a deterministic view of causality, we say that aspirin treats headaches only if no single observation shows otherwise. In probabilistic causation, we compare the outcome probabilities. But if we cannot get the results of alternative treatments in the same units, we cannot find these probabilities from observations. Instead, we should look at counterfactual quantities. How about probability that outcome doesn't occur in the absence of treatment, given that the outcome and treatment took place? In a thought experiment, we consider probabilities of how the outcome might be different. We take treatment outcome that happened in one context and imagine it happening in another. Counterfactual queries is our way to see beyond the data. Without them, we would be forever describing what happened in the past. So here's the main idea of this lesson. Informing policy often leads to counterfactual reasoning. You learn that data, not experts' opinion, is the basis for medical decisions. You learn that the counterfactual questions cannot be answered by data alone. And don't miss the most common type of what-if reasoning in public health policy. The risk reduction that could have been achieved if exposure had been reduced. You watched another episode of Causality with Boris. Keep on watching.